My job is to pitch the pure, full-time academic surgery models. My first disclosure is I am not Mark Talamini, who is sitting in the front row. We're good friends, but yes, our hotel rooms have been confused, our registrations have been confused, so he's my twin brother in academic surgery. So, my story is I was at Johns Hopkins for 31 years, arguably one of the best, finest academic surgery programs over a long period of time. So that was one market, one experience. Then I was chair of surgery at UC San Diego for 8 years. Very different market, highly managed market. And now I'm on Long Island at Stony Brook State University of New York. So I've worked for a private academic organization, highly performing. I've worked for state universities, but always in an academic, highly academic, full-time employment environment. And all of those were such that really the only surgeons that worked in our operating rooms are the full-time academic surgeons. So that's the world that I come from. So I'll just tell you, I think academic surgery is the best job in the world. And, you know, I tell people that if they didn't pay me to do it, I think I would pay to do it. And who knows? We may get that opportunity. So no matter what anybody says, lots of doom and gloom out there, particularly about academics. Don't buy it. This is the best job in the world. But it is changing very dramatically. So surgical careers in 2015 as a framework, you've already heard a lot of this. What's happening? There are a lot of repercussions of the Affordable Care Act. This is not a political statement. The Affordable Care Act has done some wonderful things. There's a lot of people, including one of my sons, who's now insured that wasn't previously. So it's done a lot of good things. But one of the things it has done, by hook or by crook, this might have been intentional, it might not have been, is the small, you know, the onesies, twosies, small group private practices, they can't survive in this world. It's going to be increasingly difficult. We talk about electronic medical records, meaningful use, all of this stuff makes it almost impossible. So the world is shifting. People are becoming employed. So it's less and less a question of whether you're going to be in a pure private practice environment by yourself or with a couple of people. Now it's a question of who you're going to work for, not so much what the style is going to be. Third-party reimbursement is decreasing. There is going to be a shortage of general surgeons. Now, I'll tell you, I wouldn't want to be, is this being recorded?
Yeah.
Oh, I got to be careful. I wouldn't want to be in a room full of radiologists right now having this talk, because I think we're a couple of chips away from not needing radiologists at all. So if I were an anesthesiologist, you know, they're working on the surgical home. Some of you have heard about that. That's because they're worried they're not going to have a job to do. Nurse anesthetists can do most of what they do. That's not true for you guys. There's only so many surgeons, and there are going to be a lot of people that need operations, especially us old people that are getting older. So you are in a very good position. There's going to be a shortage of surgeons. No, there's one now, and there's going to be an increasing shortage of surgeons. So third-party reimbursement is declining, right? The insurance companies are paying less for what we do. Medicare is paying less for what we do. Fact number one. Fact number two, there's a shortage of surgeons. Fact number three, the salary tables, the MGMA that you heard about, AAMC tables, they are either stable or they're going up. So how's that going to work? The market is saying your salaries ought to be here. The reimbursement is coming down. There's a gap there. Where's that money going to come from to pay you guys? What's the answer? Where's it going to come from? It's going to come from systems. It's going to come from hospitals. And that's going to be a big issue, is where's that gap money going to come from and how are you going to get it? Now, even in a completely capitated world, and I'm told now, Dr. Ahuja, that Maryland is a capitated world, right? Surgeons go from being rainmakers in the organization to being one of the biggest cost centers in the organization. So all of a sudden, you go from if you do a whole lot more operations, you make more money for you and everybody else, to if you do a whole lot more operations, you cost everybody more and you make less money. How's that going to work out? Well, I'm here to tell you that, the phrase is surgery drives the enterprise. I am absolutely convinced that in a capitated world, that is still going to be true. It might even be more true. Now, why do you think I would say that? Anybody agree with me, or you want to throw tomatoes at that concept? It's not a widely held belief. Why would surgery be more important in a capitated world? So, the new world is going to be about population health, right? Surgical approaches are the most effective means of population health for a ton of the diseases that we care for. Just think about it. Cancer. We are not going to cure cancer. There's not going to be a pill. It's going to be managed. It's going to be diagnosed earlier and treated earlier. That means there's going to be more operations to do, not less, right? Think about morbid obesity. There is a ton of data, no pun intended, that shows that surgery is by far the best approach. So if we're really going to be honest about population health, surgery is going to be even more important than it is now. So I am convinced that for the smart systems, surgery is going to continue to drive the enterprise. Okay, so I want to talk about the advantages of full-time academic employment versus the disadvantages. Let me just ask you all, especially the residents that are out there, what do you think would be some advantages to you working in a full-time academic employment situation? What do you think?
Speak up, don't be shy.
Say what? Go to more conferences. Like this, I'll buy that. What else?
Less calls.
The opportunity to be involved in teaching, I heard. What else?
Less calls. Private practitioners are always on call.
Less call. Possibly. Maybe not, but possibly. What else? Advantages. Protected time for research. What else? Collaboration with colleagues. What else? Potentially more complex and interesting cases. What else? Resources, maybe. Depends on the system. Okay, so what about some disadvantages? Say what? Less money. Less money. What else? I didn't hear it. Bureaucracy. Fair enough. Dr. Stain, do you ever have to deal with bureaucracy? What else? Disadvantages. Disadvantages. So I've got a list here, but before I go through my list, here's what I tell medical students and residents about academic surgery, okay? The world actually needs more great private practice surgeons than it needs great academic surgeons. If you think about the numbers and the number of people that need surgical care, the world needs more great non-academic surgeons than academic surgeons. The difference between the two careers is this. If you are in practice and you're not involved in teaching and research, you're going to go through your career and you're going to take care of, who knows, 12,000 patients, an entire career. I don't know what the number is. And that is a very special thing that you've done. If you do academic surgery, when you finish your career, you're going to look back and surgery will be different because you were there. Okay? There might be new operations, new cures for diseases. At the very least, there will be a set of medical students and residents that you have invested in for the next generation. That's the difference between the two career paths. It's when you are done with your career, you will have changed the world of surgery. And to me, you can't put a price tag on that. There's just nothing better than that. So that really is, to me, the heart of the difference between those two careers. But let me be more specific here. Somebody said, colleagues, you should be with a group that has aligned goals. If your department has been put together intelligently, you got a bunch of people, both in your department and in the organization, that want to do the same things in terms of moving surgery forward. You should be, if you're in an academic center, you should be in a place where the tripartite mission tempers the drive for profit. So we've heard about some of the systems that people work for, and this is not a criticism, it's just a fact. If you're working in a for-profit system that has shareholders, that group has to answer to their shareholders, their owners. That is their most important value. Now, obviously, they're going to say their most important value is patient care, and it should be. But at the end of the day, they have to answer to shareholders. If you're in an academic medical center, it's a different set of things that you're answering to. That organization should be answering to, are we moving these fields forward? Are we educating the next generation? So that tripartite mission should temper the bottom line mentality that we all have to live with. University benefits, no small thing, man. You know, it's not as good as it used to be, but folks who signed up like in the late 80s with the University of California, it's a beautiful thing if you've been there your whole life. You retire at nearly full salary. Still, university benefits are very impressive. You've got many committed colleagues with you, and you've got what we're talking about with these meetings, a national and an international professional life that is very, very special. It's a very special thing to be involved in academic on the national and the international stage. Okay, disadvantages. So I put down here reduced compensation. I'm not sure this is true anymore. It may still be true in some corners, but as I see more and more people coming into the fold, I'm not sure that the differential between academic and non-academic pay is as big as it used to be, particularly if you put the benefits into the equation. You do have less independence. You know, if you're in an academic center, you work for a boss. And, you know, just like we just heard, there are going to be some times when, you know, your chairman or your division chief says, here's what you're going to do Tuesday afternoon. And there's not a discussion. That's what you're going to do Tuesday afternoon. Same thing there. Political instability. You know, you've all heard the stories. I think the days of the 20-year chairman are largely in the past. The chairman jobs now are much more like CEO jobs. Your average CEO tenure is 3 to 5 years. Your average dean tenure is 3 to 5 years. For whatever reason, I don't quite get it. There is an inherent political instability right now in academic medical centers, so that is something to think about. And there are inefficiencies in a lot of these systems. And you know, if you're gonna pursue an academic career, it may well involve moving a couple of times. And when you have professional families where you have two academics, husband and wife, that can be very, very tricky to move. Okay, so I just want to go through, I have 2.5 minutes left, a couple of hints if you're looking at academic jobs. Number one, you want to know who is really in charge, who you're really going to be working for. We heard about the complexity these days of having multiple bosses in matrix situations. You want to know who you're really going to be answering to. Second thing, if you're looking at the position advertisements, in academic settings, you've got to ignore those a little bit, all right? Those are what we call hunting licenses. So, you know, you may be a highly trained colorectal surgeon, and, you know, you're looking at a job, and the job description says general surgeon. You think, I'm not a general surgeon. Don't pay no attention to that. That's, you know, particularly in state systems, you've got to get these ads out there, and they don't necessarily say what the job is really going to be. I would tell you, in this day and age, you want to measure the CEO and or the CFO in the organization. Because of that gap, that's where the money is going to come from. So you want to know who that person is and how they approach life, even in an academic environment. So I'm going to tell you the converse of what our last speaker just said. Relationships are more important than legal documents. Now, what do I mean by that? And your relationship starts before you begin employment. So you're going to be in this phase of negotiation if you're looking at an academic job or otherwise. You're going to get a letter and a contract. I'm here to tell you that no matter how good your place is, some elements of that letter are not going to come true. That's just the way life is. Circumstances change. It's not your boss's fault. It's just the way things are. You got to figure out how you're going to deal with that. So the relationship, the ability to look across the table at the person you're going to work for and trust them based on what you know about them or even your interpersonal feeling is really, really critical because the letter is not always going to be there. In addition, your relationship starts before you start to work there. So if you're in a hard knuckles negotiation and you get some wonderful concession that's in your contract and man, you're going to get that thing, it might be at a high price tag once you start working there. So you just want to think about that a little bit. Your relationship starts before that contract is signed. And the last thing I would tell you is do a lot of due diligence on the chair. Talk to people who've worked for that chair, figure out who that person is, because that's really going to be your boss. But again, having said all that, it's the best job in the world. I'm very convinced.